Thank you for being here, all of you, and thank you also for inviting me here to speak with you. Just like Shirley, I really, really believe in movement. And so when they asked me to speak again this year, I thought, I know I'm following Shirley, so I can't do the same thing she's going to do. So I'm going to try and bring you something new in motor control. And I hope it can add to what you're already doing. Motor control, I chose this topic, motor control and hamstrings, because motor control is fundamentally what we as physios should do or do. We're specialists in movement. We should be looking at movement, we should be analyzing movement and correcting movement when there's a problem. And of course I chose hamstrings because we all know that hamstrings, especially in sports people, can be or is a big problem. So basically I'm going to talk about the extensibility problem, or as in Shirley's words, the stiffness problem in the hamstrings. And as we know, if there's a problem in the stiffness of a muscle, then in a sport you can actually injure the muscle itself, but you can also cause what Shirley would call a stiffness, relative stiffness problem, so a restriction somewhere in the kinetic chain. And that restriction will cause you then, of course, to overload or injure somewhere else. And we also know that there's a difficulty in dealing with hamstring hyperactivity. It keeps coming back, and stretching doesn't work. It's not the right. It's the right problem. It's a recruitment problem. It's not a I need to stretch problem. So can we consider extensibility problem to be a motor control problem? And my answer to that would definitely be yes, we can. It's a recruitment problem. And so therefore, let's look at muscle tone. What does muscle tone mean? It's a sum of the mechanisms, active and passive, that resist the lengthening of a muscle or influence movement. So human resting muscle tone is the passive tonus that we have in its intrinsic factors. And that's the part, if we want, that the stretching could really work on, right? But the greater levels of tone are provided by the active muscle contraction. And that can be obviously on a conscious, voluntary level. But we have to remember that also tone is affected or mediated by reflexes. They can be the spinal reflexes, of course, and they can also be the brainstem reflexes. What about the definition of motor control? And motor control is thought to be the information processing carried out by the central nervous system. So that's where we get the recruitment part, and the command part. Is processing carried out by the central nervous system, organize the musculoskeletal system to control posture, to create coordinated movements, and skilled actions. And of course, this process is very complicated. And if we want, we can divide it and think about it in different parts. So one of the parts, of course, is the sensory information. We need sensory information from ourselves, inside ourselves, and from what's around us. We need to be able to perceive ourselves, what we need to do, the task we need to do. So the brain needs to perceive in order to be able to properly recruit, and all the environment around us. And then we go ahead with planning or decision making. So the brain then makes a decision in its programming. And in the end, we get an action or a reaction. So when we're talking about motor control, we're talking about a reliable sensory information coming from all the different sensory organs of the body. And this sensory information has to have minimal incongruences. They should be saying the same thing, or basically the same thing. Otherwise, it becomes a bigger problem for the brain to decide what he's going to do. From that sensory information, there will be a decision made, and we will get modulated slow motor and fast motor unit recruitment. So we're going to get the proper amount of recruitment for the task involved. So what happens with sports people, it seems to me, we very often get way too much recruitment in everything. And it's not modulated for the task they're being asked to do. And they're almost fighting themselves when they try to lift their arm. And so this recruitment, this proper recruitment, will give them sufficient control, strength, and sufficient endurance for whatever tasks they need to do. So whether it's a low load or high load. We can have barriers to motor control. And I think it's very important as physios now that we begin to look at the body not just as a muscle or a joint, but we start to think of the body as a whole body. And so there's lots of things that can change muscle tone and be a barrier to motor control. So one of them can be the sensory information. The sensory information isn't coming in clearly or isn't coming in even at all. Or we can have primitive reflexes being present. Or we can have postural reflexes not being present when they should be. Or we can have spinal reflexes changing the loop and the tone in the periphery. We can have actual problems in the muscle itself. So the muscle itself can be weak, not have enough contractile tissue. We can also have a muscle that's too long. But we can also have problems in mobility in the neurodynamic system, in the fascial system, we're going to hear more about that today, and of course in the joint. But there's another thing we need to think about. The body is chemical. We're fundamentally based on chemistry. And so we have to remember that fears, beliefs, anger, the past experiences they've had, but also the genetic and the hormonal factors are all going to change the chemistry of the body. That can maintain pain, that can also maintain tone changes, so muscle tone changes. And last, but of course not least, is the brain's ability to perceive all the information that's coming in, to modulate the information, to make its decision, and in the end, to allow us to have motor learning. Motor learning is based on the ability of the body, of the brain, to perceive what I need to do and how much I need to use to do it. So the barriers, to me, represent the underlying mechanisms that we need to talk about, we need to look into, that make it difficult or even impossible to feel, to perceive, to make a decision, and to react, which is motor control. It's what we're supposed to be teaching our patients. So any one of these barriers can cause and or maintain increased muscle tone and therefore decreased extensibility. Muscles can become hyperactive or recruit too much in the presence of impaired neuromotor function. So the examples can be in the presence of primitive reflexes, sensory motor deficits, neural protection, central sensitization, so a change in the chemicals of the nervous system, and of course, as Shirley was very, very much pointing out, the global muscle imbalance. So our therapy has to aim at looking at whatever is the real problem that is underlying, okay? Especially those patients that don't get better easy by teaching them, but you're having trouble teaching them. It just doesn't seem to work. There's got to be some underlying factor that's maintaining the problem. So for today, in the short time I have, I would like to just quickly show you what I mean by the presence of primitive reflexes and one of the possible sensory motor deficits and what we can do about it. So, can we influence hamstring muscle tone? So we're going to look basically at the hamstrings at this point. Yes, we can. We can by changing perception. Okay? If you listen to your patients, and I really do listen to what they tell me, and if they tell you, but I can't relax the muscle, or I don't feel it, they're basically telling you they don't perceive. They can't perceive what you're asking them to do, right? So there's a lot of research being done now on 2-point discrimination, so a tactile training. And we can use actually a tactile training to change the sensory cortex, primary sensory cortex, and change perception. And I'd also like to talk about reflexes, as I said. And all of us, reflexes, primitive reflexes are there. They don't go away. They're there. They're just being integrated in the higher centers, right? So they're being overridden by the higher centers. But they can come back. And they can come back for many reasons. Pain, for instance, a trauma, some sort of trauma, big trauma, some sort of stress problem. And so they can come back and they can maintain a changed tone in a very gross manner. And that can give you a movement problem. So let's go back to perception. And let's look more at what exactly I'm talking about. In the presence of pain, we know that the sensory information is changed. And the brain's ability to perceive the body correctly is often altered. And there's tons of articles out there that are showing you this. And they're also, though, showing you that tactile acuity training can change the perception. So can change the brain's ability to perceive. So we took that and we looked at, generally we use it for trying to help the patient feel better where his body is, where his shoulder scapula is, where his lumbar spine is, but you can actually use it for working with a muscle as well. So just to show you the importance of tactile training, one of our instructors, Valagusa Giulio, is living and working in Milan in Italy, works with the students at the University of Bicocca and has done several research projects with them. This is one of the first ones they did, where they actually took chronic low back pain patients and they treated them for 6 weeks with just tactile acuity training. So just TPD, 2-point discrimination training. And after the 6-week training, they compared them, of course, to the control group. There was not big changes in the control group, but the group that they had trained changed their pain. They changed their TPD. It was much improved. And they changed their function. But what interested me most of all is that in their testing, they did a battery of Shirley's motor control exercises, tests and exercises. They didn't do one exercise, not one exercise, but the exercises all changed. So what I'm telling you is TPD can change movement. Right? If the body can perceive, if the brain can perceive, it can change movement. So this is a little bit what we do once we've measured how far it takes them to feel 2 points. Then we can put. Do you have a laser here? Yeah. Okay. So then we can put numbers on their legs and take a picture so they can see. And it has to be their leg. They can see that, right? And then we just lightly touch a number, okay? And they have to tell you which number you're touching. So you can start with like maybe number 2 and then number 8. So you can start with numbers more distant. And as they get better, you can go to numbers closer together. Right? And once that discrimination starts to be better, and this changes within one sitting. You're sitting there and you do it, and they will change, right? You can then add on a dynamic 2-point discrimination. So you can add on movement, and what that does really is adds on another component to perception, because now there's a movement component in it. Okay? And so if we look, we can ask them then, I'm going to move from one number to another number. Can you tell me where I'm going? So they'll say, okay, you're going from 2 to 11, or you're going from 11 to 2. And gradually that gets better as well, because sometimes they'll feel it completely diagonal when you're actually going up and down. Okay, so once that starts to change, then you can actually use that to work with your imbalance. So very often, as you know, you get this really hyperactive hamstring muscle, and you get the glutes that are not doing anything at all, right? They're not doing the job, right? And they'll tell you, I can't feel it. I don't know how to get that glute contraction, right? So if in the hamstring, you can actually ask them to imagine the 2 points, number 2 and number 11, and let the 2 points go. So just release it. And within one setting, they can actually start to feel what they have to do to let go. And in the same way, you can do exactly the same thing on a muscle that's not reacting very well, they don't know how to to get that contraction. And you can ask them to draw the 2 points together. Okay? And you can get some tone coming into the muscle, and they can start feeling that muscle. So that's basically what we do with 2-point discrimination. And it gets easier and better, and finally they perceive really well. So primitive reflexes is another story. It's another thing, but I really wanted to bring it today. It's something different. So primitive reflexes are brainstem-mediated, complex, automatic movement patterns, very gross, which are evoked through sensory stimulation. And that stimulation can be vestibular or it can be tactile. And they have been seen in healthy populations. And I guarantee if I test all of you, most of you are going to have some sort of remnants of a primitive reflex. Somebody, of course, that we're going to really want to treat is going to have a very important primitive reflex, not just a little thing. Okay, so anyway, we see them in healthy populations, and there's been enough work showing that primitive reflex will actually influence your ability to do specific motor control exercises. So they'll act as a barrier. So when we look at assessing a primitive reflex, we cannot assess in an older child or in an adult the way we can in a baby. Okay? And you can't expect to see the exact same things you're going to see in a baby. So we've taken what they're using when they're teaching children with learning difficulties, and we've put it onto patients with also difficulties, patients that you're having trouble teaching. And so what you have to do is you have to treat them in another way, using the same aspects as a primitive reflex assessment. So basically you can't with an adult, obviously, because they have muscles already, and they've have learned methods of compensation, and they've also got variable patterns of cortical inhibition. So they will never show up, as you will see with a baby. But you can stimulate the reflex, and you can see it. And very often, if you start using them, and you'll start seeing them in their active movements, okay? And then you'll say, aha, that's a reflex coming out. And you can go and treat it, and that will help the active movement. So a reflex can be stimulated by actually carrying out a normal reflex pattern assessment, by exaggerating a reflex pattern with weight bearing or load, or we can use part of the reflex pattern and see whether the rest of it comes out, right? So I'll show you examples. But first of all, many reflexes, primitive reflexes, will have effect on the hamstring tone. So Landau, foot tendon guard, symmetric, asymmetric tonic neck reflex, spinal galant, the Moro reflex in extension, spinal Perez reflex, and the Babinski reflex. And there's probably others, right? So obviously couldn't do all of those today, but I thought I'd show you probably the two more important when we're talking about the hamstrings. So if we're going to test for it, we're going to ask this, the Landau is vestibular driven reflex. So we're going to ask the patient simply to lift her head, so actually lift the chin, because we want the vestibular canals to change. So if she lifts her chin, what I'm going to do is then feel for lumbar tone and hamstring tone, right? And you should get pretty well nothing, especially in the hamstrings, okay? If that doesn't give me a positive, then I'm going to add load, or I'm going to add more of the gross movement so I can see whether I can get it. So this is a physio, and we were in the course, and we were doing the Landau reflex, and this is what she was asked to lift her head, shoulders, and arms, and this is what came out. Can you show the video, please? Okay, and she's only asked to lift her head and shoulders, right? And that's what you see, right? And so it's an extreme extension pattern. Okay, so what am I going to do with this? I found it. I know it's dominating the muscles. that are the gross muscles, the long muscles, how can I do something about it? So I need to ask them to actively and consciously, and those are the big white words for a big reason. That's the really important thing. It's the active and conscious part. I need to replicate the primitive reflex pattern. So I need the higher centers to do the job, and not the brainstem. It is believed that the conscious replication of a reflex movement pattern mimics what we normally do in the neurodevelopmental process, where the primitive reflexes are naturally inhibited by the frontal lobe. So this is what we think we're doing. Okay? So how do I treat it? I'm going to ask her to perform the reflex pattern against a slight resistance, but enough that she's going to know it's there, right? She's going to have to think about keeping that position. And she's going to hold it for 5 seconds, maybe even 10 seconds, and let go. And then she's going to do it again. And it's going to be 5 times, maybe even 10 times. It depends on the strength of the reflex, right? So you're going to treat it, and then you reassess it. If it's still there, you do it again. And if it's still there, you do it again. Some of the very strong reflexes don't disappear or aren't overridden by the higher centers in one treatment. You'll have to do it again. And they have a home program to do. So they're actively going to repeat this at home, right? So if we look at the girl that was then treated, of course, in the course, and this is, can you show that video? Yes. So this is the difference. Can you repeat the video again, please? So she asks to lift her head and shoulders again, and this is what you see. Now she's still getting some tone, and she shouldn't, right? In the end, she shouldn't, right? Definitely the hamstrings will bring in tone, but she should not get any lifting of the feet off the bed. The other reflex that I said I wanted to show you is the foot tendon guard. It's a reflex, again, creating the extensor pattern. And it fundamentally is a reflex that is trying to protect the Achilles tendon. And it's about like a bit opposite to what the Babinski reflex is. So it's a tactile driven reflex. And so when you touch the medial border of the foot, you see what happens. Can you let that go, please? Okay, so watch the toes. So as you stroke the medial border, the toes will curve, and what they'll get really is a full extension, tone changing, right? If that's not enough, if I don't see anything, but I have doubts that it's there, that there is something there, but I need to load it more, I can ask them to actually walk on, or if you're just looking at walking, and you ask them to walk on the medial border, and you start to see funny things happening, think about a reflex. Okay? So this boy walks normally, and when he's asked to walk on the medial border of his foot, this is what you see. Can you set that reflex? Okay, as he comes back, you'll see he tries to let go, right? But he's getting a complete extension pattern. Now, this is a normal child. This is not a neurological problem. Okay, so that's what a foot tendon guard reflex looks like. And when you treat it, I'm sorry we don't have the video after we treated it, but when you treat it, it will change. Okay? Normally, if you don't have it, you can walk on outer border or an inner border of your foot and it doesn't change anything in your body. Right? Okay, treatment of the foot tendon guard, because it's a sensory-driven reflex, so the first part of the treatment is a deep, slow massage, trying to desensitize the area. Okay. And the second part of the treatment, and the part that they then repeat at home, is curling the toes down, push down the foot into plantar flexion, leg into the bed, shoulders back, push your hands into the bed, etc., etc. So they go into a full extensor pattern. And again, 5 seconds, 10 seconds, hold, let go, 5 seconds, 10 seconds, hold, let go, and then you reassess. If it's still there, you do it again. So the treatment strategy of primitive reflexes, or TPD, is to reduce, at least temporarily, the muscle tone of the hamstrings, allowing a window of opportunity for treatment. And I really want to stress this part, okay? Treatment of only the hyperactivity is definitely not sufficient. That's not what we're talking about. We're just talking about getting rid of a barrier for a while, at least for a while, so that we can then go ahead and increase our motor control. So increasing the perception in the area or inhibiting the primitive reflex that is increasing the tone, that is causing our tone problem, is allowing us to do a more complete treatment program to correct movement patterns, to correct the kinetic chain sequencing and timing, and to correct the muscle balances. So to do exactly what Shirley was talking about. All this is a facility to what Shirley was talking about, which I truly believe is important. So therefore, we'll get our long-lasting results. My take-home message for today, let's not forget the muscle tone is heavily influenced by our sensory system and by our psychological state. And the underlying mechanisms responsible for any apparent muscle hyperactivity should be sought, should be treated, and that way, hopefully, our treatments will become more effective. Thank you for your attention.